Yeah, hi doctor. So basically, in these CCS, that is the core, the case, you will be given with a situation, and in that situation, you will first have to make a diagnosis, and then follow it up as and when the case progresses. So I would like to reiterate this case, who was a 58-year-old male who presented to the emergency department with acute severe chest pain radiating to his left arm and jaw, associated with diaphoresis and nausea. Pain started 1 hour ago while at rest. He has history of hypertension, type 2 diabetes mellitus, and he is a chronic smoker. On initial assessment and arrival, the patient's blood pressure was 90 by 50 and heart rate was 110, respiratory rate 24, saturation 94% on room air, and ECG is what you see in the screen. There were elevated cardiac troponins and there was normal renal function and blood sugar was 180. So can anybody tell me what the diagnosis is here? I would like you all to contribute for the maximum benefit that you can get from this class. So this basically is an ECG showing ST elevation in V1 through V5 up to V4 and reciprocal ST depression in lead 2, 3 and AVF. So by all means, with the case presentation, this patient looks like anterior wall STEMI. Now, the examiner is bound to ask you after the diagnosis is confirmed that what is the differential diagnosis for this condition. Anyone? I don't think anybody is interested in this deliberation.
Sir, this is a debriefing session. This is optional. If students want to join, they can join. If they don't want to join, there is no hard and fast rule. You continue the class.
Who am I debriefing then? Anyhow, so this is anterior wall STEMI. So once the diagnosis is made, the examiner is bound to ask
Aspirants,
you.
please respond to Dr. Varun Pushkarna's questions.
So once you have the diagnosis, you should know the way forward as to how you are going to stage the disease and then plan according to the stage of the disease as per the guidelines and recommendations. So this patient has coronary artery disease and stage of the disease is acute anterior wall MI, that is a STEMI. So in case of STEMI, the way forward is immediate dual antiplatelet therapy, giving them oxygen in case of if the saturation is less than 95%, giving them DAPT along with anticoagulation, and if and a statin also. So in high doses. And the point is that if nowadays every place has facilities of cath lab, so this patient need to be immediately shifted to cath lab. In a real third world, if the cath lab facilities are not available, the diagnosis, after the diagnosis is made, the treatment will be thrombolysis. Now the examination people who are conducting, they can ask you about the thrombolytic agents approved for thrombolysis in ST elevation MI, if it is gold standard, if it is at par with primary PCI, and they can ask you about the various injections that can be used in thrombolysis and their mode of administration. Some drugs are to be given as infusion, some drugs are to be given as double shot, some injections are to be given as a single dose bolus therapy. So, after thrombolysis, as in whole of the Europe, the facilities to do a primary PCI are routinely found in each small city also. Hence, the patient is to be taken up for cath lab. And the door to balloon time is the question which is routinely asked. Door to balloon time is basically 90 minutes. And in facilities where the the cath lab facilities are not available in house, in that situation, the patient needs to be shifted to a cath lab facility. Then the duration is permitted to be 120 minutes. So now that you've made the diagnosis of acute anterior wall myocardial infarction, you will routinely check the airway, breathing, and circulatory status of the patient. Once you check, immediately you start with the dual antiplatelet therapy, in which there are two antiplatelet drugs to be given. So one of them will be aspirin, and the other of them can be clopidogrel, ticagrelor, prasugrel. So out of these three, you can easily use the other drug, beginning with ticagrelor. Now, almost all the guidelines and recommendations in Europe, even the CSI, everybody is recommending ticagrelor as the first option to be given with aspirin in DAPT. Along with that, high dose statins are to be given, anticoagulation, either unfractionated heparin or heparin, low molecular weight heparin has to be given. And if the chest pain is too much, and then morphine is also recommended along with nitrates. So once you have activated the cath lab, you have to transfer the patient with the recommendation timeline of 90 minutes. Now you need to be very well versed with the cath lab images, because they can show you images and ask you about the possible site of obstruction. In this case, the site of obstruction was LAD. And once they show you a picture like this is a STEMI picture where you can actually see a cutoff sign where you cannot see a blood vessel after a particular point. This is the point. After this, you don't see any blood vessel. If it was traveling, it would have been like this. You cannot see this portion or even this portion. Then this is basically a cutoff sign. So thrombus occlusion is there. So this is the reason for acute anterior wall STEMI. So this has to be, the guide wire has to be traversed through this balloon angioplasty followed by drug-eluting stents. So what are the drug-eluting stents? Drug-eluting stents are where there is a chemical coated on the stents, which is usually sirolimus. Sirolimus is the drug that you remember from tacrolimus. So tacrolimus is a cytotoxic drug. So why is it important? So that number one, you are giving antiplatelet drugs, so in the stent the thrombus will not be formed, but later on the endothelization of the stent will happen. When endothelization is happening, you don't want there to be an endothelial cell clump blocking the stent, which is called restenosis. So as long as you are giving a cytotoxic drug, which can prevent cellular multiplication, what will happen is there will be minimal chances of instant restenosis. So this patient was taken up for balloon angioplasty and there was a drug-eluting stent placed. Then ideally there should be TIMI grade flow 3. So grade 3 flow should be there, which means as normal as natural. Of course, afterwards the patient has to be shifted to ICU for observation. What do you have to observe? You have to observe for vitals. You have to observe for ECG changes. You have to observe the patient for any obvious hematoma formation at the site of cannulation. And of course, you have to look for saturation, chest auscultation, and so on and so forth.
Tamponade.
Yeah, tamponade. How will you get to know that the patient has developed tamponade?
Vitals.
So we start with monitoring of vitals, number one. Number two, ECG. Number three, the saturation. And of course, overall visible status of the patient. What are the signs that you get in tamponade? So what is the first thing to happen in candid tamponade?
Breathlessness.
So the first thing will, so the number one thing will happen is hypotension. Even before hypotension, tachycardia will start. But sometimes what happens is we are expecting a little bit of tachycardia post MI also. So we may be taken by surprise. So first is tachycardia, second is hypotension, third is tachypnea. So all three will be there. These are the signs of heart failure. But when you auscultate the chest, there will be no clefts. Why? Because the RV is not getting filled. Tamponade means that the right ventricle is being compressed by the tamponade. So if the RV doesn't fill up, what will it give it to the left ventricle? So if you look at the tamponade, and as such we know the right ventricle has a very poor muscle. Okay. So this is the RA. This is the tricuspid. This is the left ventricle. Can you appreciate this? So this is the pericardium. So this is the collection of blood. Okay. So this is causing tamponade by compressing the right ventricle. So this means right ventricle, the blood supply that goes to the LV will be decreased, so that usually the chest will be not having any clefts. But there will be in the JVP, what you will see is, yes,
Raise JVP.
so will you see pulsus paradoxus? Kussmaul sign? Yes. So you will see.
Yes, sir.
So you will see pulsus paradoxus in case of cardiac tamponade. So how will you confirm that the patient has developed a cardiac tamponade?
Echocardiogram.
Echocardiogram. So in cardiac tamponade, what do you see on echocardiography?
Sir,
RV
RV collapse and diastole. No diastolic filling of RV.
Yeah, so there will be diastolic collapse of the RV, but when does tamponade start? So you will like to calculate the volume, right? So in the echocardiography, anything which is more than 20 mm, you will have the doubt of the collection. If it has not yet caused tamponade, it will cause tamponade. So what are the 3 Ds of tamponade? Distal heart sounds, distended jugular veins, drop in blood pressure. So these are the 3 Ds of cardiac tamponade. And what will cardiac tamponade lead to? It will lead to cardiogenic shock. It will lead to
Obstructive shock.
cardiogenic. Yeah. So basically, there will be cardiogenic shock. What is Beck's triad?
Hypotension, raised JVP.
And Kusumal's breathing.
So there will be hypotension, raised J. Abhi to bataya the 3 Ds. All of them are Beck's triad. Drop in blood pressure, distended jugular veins, and distant. So muffled heart sounds.
Muffled heart sounds.
Muffled heart sounds. So this is known as Beck's triad. Okay. So this patient whom you have taken up after primary PCI for anterior wall STEMI suddenly becomes hypotensive, confused, and drop in saturation, drop in blood pressure, peripherally cold, clammy peripheries, urine output drops. This is, it should bring to your mind that the patient might have had a cardiac tamponade. Okay. So what if the patient has cardiac tamponade? What are the immediate goals?
Relief of the pressure. Pericardiocentesis, a drain in the pericardium.
Very good. So immediate goal is to relieve the heart of the compression by letting go of the volume. So you do a pericardiocentesis. So relieve the intracardiac pressure, intrapericardial pressure, and stabilize the hemodynamics. So you will first rush the fluids. So you rush IV fluids, add vasopressors. That happens immediately, right? But once you get the echocardiography, then you can do ultrasound guided pericardiocentesis. So what are the indications for surgical thoracotomy in this patient, emergency thoracotomy? What are the
Sir, any free ventricular wall rupture, VSD, any MR, severe MR, secondary to wall ischemia?
So for tamponade only. So for tamponade only, it is the number one resistant kind of a tamponade that can happen in free wall rupture. Okay. And I always tell, if it is a case of inferior wall MI or true posterior MI, the chances of free wall rupture are more. Why? Because right ventricle is a thin walled structure. So there are more chances of rupture, RV rupture. And then, of course, many times in inferior wall MI, the patient requires a temporary pacing lead. Sometimes temporary pacing lead perforates and through the right ventricle wall and leads to tamponade. Okay. So these are important. Number one. Number two, watching for early signs of reperfusion injury. So what are the early signs of reperfusion injury in ICU?
AIVR, sir.
Okay, so AIVR. What else? So you suspect that the patient has been stented and now has come. So first thing is you will get abnormal ECG rhythms. Any of them can occur. Yes. So you will watch for reperfusion arrhythmias. Second, sometimes what happens is patient starts to have chest pain. Patient again starts to have chest pain. ST doesn't resolve. Okay. So patient having AIVR, patient having other rhythms like ventricular tachycardia, ventricular fibrillation, which are literally present only for transient period, but are still there. Okay. Fine. So watching for early signs of reperfusion injury and arrhythmias is important. So what three things you watch is looking for tamponade, looking for reperfusion arrhythmia, or looking for any reperfusion injury. Then there is another condition which is known as post stenting no reflow. So that is a rare condition where the patient was stented, but thrombus or some light thrombus was present already in the blood vessel, and the ballooning was not done properly. Post stent dilatation was not done properly. So there are chances that the vessel blocks again, leading to no reflow. So the reflow doesn't happen. This leads to a ongoing MI to the patient. So in our case, what happened was this patient, he developed shock. He went into 70-40 BP. Heart rate went up to 130. The patient had cold, clammy skin. JVP got dilated. Pulmonary edema was present. Urine output dropped. So what does we have? We did an echocardiography. There was no tamponade, but the ejection fraction of LV was decreased significantly. It was only 25%. There was anterior wall akinesia. So we introduced a Swan-Ganz catheter. We found that the patient has a low cardiac output and high capillary pressures of the pulmonary capillary wedge pressure. CVP was elevated. So what is the diagnosis now? Post-MI? What is the diagnosis now?
MR, sir.
So the
Severe MR.
No, in echocardiography, nothing of that was mentioned, right? So we just severe reduced LV function, anterior wall akinesia.
And
No
thrombus.
MR.
Cardiogenic shock.
Yes, so it is post-MI
Cardiogenic shock.
cardiogenic shock. How do you diagnose it? What are the diagnostic guidelines? So these are the definitions. So these are all the questions that you will be asked for every word that you say. So cardiogenic shock, what is the definition? Blood pressure less than 90, features of end organ hyperperfusion, like cold extremities, confusion, oliguria, rising lactates, dropping cardiac index. Then you have to classify the heart failure, the CCF or acute LV failure. You have to classify as biventricular, LV predominant, RV predominant, cardiogenic shock, or non-congested, cardiorenal, cardiometabolic. These are the other types of cardiogenic shocks. Identifying the cause is very important. This list will be asked. Acute MI, post-cardiac arrest, arrhythmias, conduction disorders, infectious diseases leading to myocarditis, iatrogenic cardiogenic shock. Where do you see iatrogenic cardiogenic shock?
Cardiac tamponade. Cardiac tamponade.
Say again?
Sir, IABP.
Cardiac tamponade.
Yeah, iatrogenic is cardiac tamponade. You happen to, and then of course dissection of the coronary arteries while working on them. So these are iatrogenic causes of cardiogenic shock. Many times what happens is patient is in atrial fibrillation. You try to do a cardioversion of the patient and patient degenerates into ventricular fibrillation. The patient otherwise was running fine in atrial fibrillation. The only thing he had was dizziness and hypotension. And when we gave this DC cardioversion, the patient ended up in ventricular tachycardia. This was a definite cause of cardiogenic shock and iatrogenesis, because we did something and only after.
Sir, do we define cardiac tamponade as an obstructive shock or cardiogenic shock, sir?
See, it happens because of the non-filling of the right ventricle of the heart. Yeah. So it is the genesis of the shock begins with the involvement of the right ventricle, begins with the involvement. From where does the pericardial tamponade in a post-MI patient develop? It will develop either due to the cardiac rupture or due to a very strong
Capillary rupture
reaction secondary to cardiac injury, isn't it? So everything started with a cardiac injury only. So it is a cardiogenic shock. Are you getting me?
Okay, sir.
Yeah. So, like in case of a traumatic pericardial tamponade, it may not be classified as a cardiogenic shock because the injury that caused it was a trauma. So it is a traumatic cardiac tamponade. Yes, now that the heart is unable to sustain, now it will become a cardiogenic shock. So basically what you have to do is, because why do we define the shocks? Why do we define obstructive, distributive, cardiogenic, neurogenic? Because we have to identify the bullseye where we have to hit and correct the injury. So if we are suspecting a cardiogenic shock, we will be looking at the cardiac status. We will be looking at how to get the cardiac system relieved of this. Are you getting my point? For example, a patient who has ascites so much so, or a perforation, abdominal perforation injury so much so that the patient develops a abdominal compartment syndrome. Now, in abdominal compartment syndrome, it is an obstructive kind of a shock, isn't it? But it is not a cardiogenic shock.
Sir,
Are you getting me?
yeah, sir. Plan of treatment is different for both of obstructive and cardiogenic. We give a drug of trial, sir.
Exactly.
Dobutamine we start for cardiogenic when we say it is cardiogenic, but we don't start it in cardiac tamponade, sir. That was a
I will
confusion.
tell you. So I will tell you what happens in such a condition where both of them are together. So this is a post-MI pericardial effusion. We do a pericardiocentesis. We decompress this thing. I'm not saying that you are entirely wrong. I'm just saying that you need to decompress first. And this patient definitely will need some kind of ionodilator dilator or maybe IABP support. Many times it happens is that the patients who have cardiogenic shock secondary to pericardial tamponade, you relieve the tamponade and the shock still not recovers. These patients will still require inotropic support for a long period of time. So it is right to classify them as obstructive, but this particular case that we are dealing with here has a cardiogenic shock secondary to acute MI, where the pericardial tamponade obviously was not the cause, but in case pericardial tamponade is there, usually both of these shocks, they coexist together. A traumatic situation might be different, but here it is a primary cardiac injury that led to a pericardial tamponade. Okay. So once you define that the patient has a cardiogenic shock, by the way, in this case, this cardiogenic shock is secondary to loss of muscle tissue. So here, it is not a mitral regurgitation. It is basically akinesia of the whole of the left ventricular wall leading to cardiogenic shock. Now, how do you proceed in this case? So how do you proceed in this case? So now you know that this patient has, so this will also be asked in the exam, that how do you proceed in such a case where you have a post-MI cardiogenic shock? What are you going to do?
We can institute, sir, either medical, like we can use circulatory shock devices like IABP. We can give a drug or trial like dobutamine, sir. If the blood pressure drops by more than 20 systolic or 20% of the heart rate, increases the heart rate, then we should stop that drug, sir.
So the management of cardiogenic shock begins with an agenda. The agenda is hemodynamic monitoring. So you will institute hemodynamic monitoring of topmost level. You will have a central vein in place. You will have an arterial line in place. You will like to keep the mean arterial pressure above 65 at all the times. To maintain these vitals, to maintain and record these vitals, you will require initially, if the blood pressure is low to begin with, you will start with norepinephrine as a vasopressor of choice. Once you get the mean pressure above 65, now you will add dobutamine in this particular case. So norepinephrine and dobutamine together will provide you with the required inotropic support here. In case that doesn't work, lactates continue to rise, urine output continues to be low, patient's heart rate continues to be high, and BP doesn't improve, mean arterial pressure doesn't cross beyond 65, then you upgrade the therapy. From whatever you are using vasopressors, you upgrade the therapy. So the next upgrade will be a intra-aortic balloon pump. So you have upgraded your management. You have started the patient on IABP. After 6 hours of IABP, the blood pressure is still 70/40. Inotropes are at a stiff dose. Urine output is not there. Lactates initially responded to 3, now again back to 9. Patient is tachypneic. Patient is on non-invasive ventilation. What next?
Intubate the patient, mechanically ventilation, and if further worsen, then VA ECMO.
Yeah. So in this patient, we would like to intubate this patient and take the patient on ventilation. And once the patient is stable, we would like to go forward with ECMO. What kind of ECMO?
VA ECMO, sir.
ECMO.
So in this case, we would like to go with the VA ECMO. So in VA ECMO, what are the parameters that you would like to set on this patient? So before putting the patient on VA ECMO, what is your take on intra-aortic balloon pump? Will you keep it or will you remove it?
We will keep
We
it.
will keep it, sir.
We will keep it.
So you will keep the IABP along with
ECMO.
You will keep
ECMO.
the IABP along with VA ECMO.
Yes, sir.
What are the principles of working of VA ECMO? So let us say you did a FEM VA ECMO, femoral vein, femoral artery. Can you do a femoral artery VA ECMO if one of the femoral arteries has a IABP in it?
No, sir.
No. Can you put blood into the femoral artery? Because in a VA ECMO, you are taking blood from the venous side and putting it into the arterial side, isn't it? So,
Yes, sir.
so you are pumping blood into the arterial side in which you already have a IABP. So what will happen is aorta will get thrombosed. Aortic thrombosis as already is a big challenge and complication of VA ECMO. In case you have an IABP there, the chances of aortic thrombosis will increase even more. Why? Because IABP is trying to decrease the SVR and VA ECMO increases the SVR. Isn't it? You are pumping the blood. See. So this is aorta. You are actually pumping blood into aorta, which is coming from the ECMO. So when the heart is trying to pump blood out, ECMO is pumping the blood into aorta, and there is a confusion here. So this leads to a complication of VA ECMO, that is aortic thrombosis. Imagine if an IABP is also placed here, it will be chaos. So ideally, you should remove the IABP when you put, because IABP has failed as already no trials have proved that IABP helps in recovery of cardiogenic shock. Although we are putting it right and left, you will not find a single positive trial in its favor. Anyhow, VA ECMO, you would like to go on it alone. You would like to keep the cardiac index and cardiac output sufficient enough for the urine output to come, let us say, cardiac output around 3.5 to 5 liters के आसपास. So this patient on VA ECMO continues to get better. So now you tell me, what are the complications of VA ECMO?
Pleural arterial thrombosis.
Sir, bleeding, thrombocytopenia,
Bleeding.
infection,
So
sir, peripheral
yes.
ischemia, PVD,
So
aortic
first,
dissection, aortic rupture.
aortic dissection and aortic rupture. Okay. So we begin with bleeding tendencies because we need to keep an INR of 2.5 to 3 on IABP. We like to heparinize these patients, and secondary to heparin, heparin-induced thrombocytopenia can also occur. Okay, so and of course, if you are not able to maintain the targets, diffuse thrombosis can also occur. Second is, of course, infections. Third is these blood vessel related problems like distal gangrene, aortic thrombosis, aortic injury of any type. So these can occur. And yes, because of the sepsis part, other things can also occur, like hemorrhage into the lungs, hemorrhage elsewhere into the body, retroperitoneal injury, and all those things. So these are the complications of VA ECMO. So let us say, okay. So this is the chart that you will need to remember for deciding on managing therapy refractory cardiogenic shock. So basically, you have to rule out certain conditions which are prerequisite, like advancing age, active malignancy, severe COPD, chronic dialysis, sepsis, another non-cardiac life-limiting diseases, cachexia, frailty, and poor health compliance. If any of them are present, then you don't go for any devices like ECMO. But if none of them are present, then you consider ECMO, or you consider implantable left ventricular assist devices if you think that the patient will require a long-term solution because you are unable to wean off this patient from ECMO. So this patient was put on ECMO, but even on ECMO, there was, we were unable to get some improvement. So after 48 hours of VA ECMO, the patient shows no significant improvement in myocardial function. What next? So VA ECMO भी लगा दिया, no improvement. What next? Should we let the patient go? We've done so much of hard work on this patient. What next?
Left ventricular assisted device?
Yes. So the next option is LVAD, left ventricular assist device. You have Impella for that. So you will discuss with the cardiothoracic surgery team. This patient will require a thoracotomy and insertion of a left ventricular assist device, and it is a bridge to decision. What decision? Usually heart transplant. So what are the complications of LVAD? So you can see that these patients who are put on left ventricle, this is the diagram I have already drawn. So this is the LVAD that has been placed. It is like a motor which is pumping the blood into aorta. So we have to go through the left ventricle, and because this right ventricle is giving blood to the pulmonary artery and to the lungs in a pulsatile fashion, but this Impella device, it does not require a pulsatile fashion. It is basically a rotor motor, so it will be not taking blood from the lungs in a pulsatile fashion. So what will happen is, initially the patient will develop a RV dysfunction. So RV dysfunction can happen, RV failure can happen, arrhythmias can happen. and these patients may require a temporary right ventricular assist device also. So, but then these are the things that you need to remember. Okay, as we've already discussed the VA ECMO complications, so these are the problems. And then, of course, left ventricular assist device complications are also there. So you have to remember that there is a drive line. There is a drive line, that is the cable through which the power is supplied to the motor of impeller. So that site can also get dislodged and infection can occur. So as this was not the last, at the end of the day, on day 7, when the patient was, we were feeling comfortable that this patient has now LVAD in situ. This patient develops acute chest pain and ECG shows ST segment elevation in anterior legs. So this indicates stent thrombosis. Then you will be wanted to know what is the management of stent thrombosis. So stent thrombosis is basically in, STEMI only, because it's a complete obstruction. So you have to take the patient again. This patient will also have ST elevation. Again, you will have to take the patient to cath lab, open up the stent, and then change the patient from whatever DAPT you are using, because on that DAPT patient developed stent thrombosis. So you need to upgrade it. If you were using aspirin and clopidogrel, you will be using aspirin and ticagrelor. So that is what is to be done. So these kind of cases, moving from a trivial looking anterior wall MI STEMI, can go up to stages from cardiogenic shock, therapy refractory cardiogenic shock, intra-aortic balloon pump, VA ECMO, LVAD, and heart transplant. So whenever you are preparing a patient case scenario for your EDIC exam, you have to come up with all the possible complications, and you should know how to troubleshoot them and what is the transient, temporary, and definitive treatment for any of those conditions. So that is all from my side. I think Dr. Khan will take over now. Thank you very much.